Good morning everyone. This lecture video will be combination of your lecture for presentation of principle of instrumentation, and there will be 3 demonstration videos. These are the contents of this lecture. Coming on to introduction. Instrument is defined as device that requires skill for proper use, and instrumentation is defined as application of use of instrument. The term instrumentarium is referred to the collection of instruments and other equipment for an operation or a medical procedure. So these are the principle of instrumentation. First one is accessibility, that includes position of the patient and operator. Second is visibility, illumination and retraction. Third is condition of the instrument. Fourth is maintaining a clean field. Fifth one is instrument stabilization, which includes instrument grasp and finger rest. Finger rest are further divided into intraoral finger rest and extraoral fulcrum. Last one is instrument activation. So coming on to the first principle of instrumentation, that is accessibility, which includes proper position of the patient as well as the operator. The accessibility should facilitate thoroughness of instrumentation, and it should provide maximum accessibility to the area of operation. The clinician should be seated so that his feet are flat on the floor and thighs are parallel to the floor. Patient should be in supine position and placed so that the mouth is close to the resting elbow of the clinician. Second principle of instrumentation includes visibility, illumination and retraction. So in first one, you have seated the patient properly onto the dental chair. Second one is visibility, illumination and retraction. And whenever required, you should prefer direct vision and direct illumination. So first picture shows direct vision with direct illumination. Second picture shows indirect illumination, in which we are using mirror to reflect the dental light onto the posterior region of the maxilla. Third picture shows indirect vision, in which we are visualizing the lingual area of the mandibular jaw with the help of mirror. And fourth picture shows indirect vision with indirect illumination. So second is retraction. Retraction is also very important because it provides visibility, accessibility and illumination. So first picture shows retracting the cheek with the help of mirror. Second picture shows retracting the tongue with the help of mirror. And in third picture, we can see how we can use the index finger to retract the lower lip when we are doing instrumentation on the lower mandibular region. Next principle of instrumentation is condition of the instrument. So whenever you are using instrument, it should be in good condition. The instrument should be clean, sterile and in good condition. What do you mean by good condition? The instrument should be sharp. It should not be dull, because if the instrument will be dull, the operator will try to use more force that can lead to trauma to the gingival tissues also. So the condition of the instrument should be always, the instrument should be sharp, it should be clean, it should be sterile. Next principle of instrumentation is maintaining a clean field. So adequate suction is essential and can be achieved with saliva ejector, or if working with an assistant and aspirator. We often use compressed air or gauge pieces to facilitate visual inspection of tooth surfaces just below the gingival margin during instrumentation. So suction is very important during instrumentation. Next one is instrument stabilization. To stabilize the instrument, we have instrument grasp and finger rests. So most effective and stable grasp for periodontal instrumentation is modified pen grasp. Why it is most important? Because it enhances the tactile sensitivity by using the middle finger, thumb of the middle finger. So palm and thumb grasp is useful for stabilizing instruments during sharpening and for manipulating air and water syringe. Tactile sensitivity are so inhibited by this grasp that it is unsuitable for precise controlled movements necessary during periodontal procedures. So these are the 3 types of grasp. First picture shows the pen grasp. Second picture shows the modified pen grasp. that is the most desirable and most commonly used grasp. And appreciate that in this grasp, the index finger is resting on the shank area of the instrument. Third grasp is palm and thumb grasp. This grasp is basically used while instrumentation. So, this is a video that will be demonstrating various grasps. Cessation in the control of movements while instrumentation. Basically, there are three types of grasp. First is palm and thumb grasp. Like this, you will hold the instrument. This is palm and thumb grasp, and this is used while sharpening of the instrument. Next is pen grasp. It is just like holding a pen. Third one is modified pen grasp, which is the most commonly used grasp. And in this grasp, you will place your middle finger onto the shank area of the instrument, like this. And the palm of the thumb is placed midway between the middle and index finger. The index finger is bent at the first joint, and the middle finger is resting on the shank area. So coming on to finger rest. Finger rest serves to stabilize the hand and instrument by providing a firm fulcrum as movements are made to activate the instrument. Good finger rest prevents injury and laceration of the gingival and surrounding tissue by poorly controlled instruments. Mostly we use fourth finger to be used for finger rest. Whenever possible, third and fourth finger should be kept together to work as one unit fulcrum during scaling and root planing. So we have two types of finger rest. First one is intraoral finger rest, and under intraoral we have conventional, cross arch, opposite arch and finger on finger. And in extraoral we have palm up and palm down. So in this picture we can appreciate this first picture is showing conventional finger rest, in which in conventional the finger rest is established on the tooth surface immediately adjacent to the working area. And in second picture that is showing cross arch, as the name suggests. Cross arch means when the finger rest is established on the tooth surfaces on the other side of the same arch. Third one is opposite arch. In opposite arch, the finger rest is established on tooth surfaces on the opposite arch. Like in this picture, we are using finger rest on the mandibular arch while doing instrumentation on the maxillary arch. Last one is finger on finger. Finger rest is established on the index finger or thumb of the non-operating hand. So this is a video demonstration for finger rest. I hope you all can appreciate that this is conventional finger rest, in which the fourth finger is resting on the tooth surface just immediately adjacent to the working area. So second one is cross arch. In this, the finger is established on the tooth surface on the opposite side of the same arch. See, this is the finger rest and we are doing instrumentation on the opposite side of the arch. appreciate the opposite arch finger rest. The finger rest is established on the tooth surface on the opposite arch. Like in this case, we are doing instrumentation on the palatal region while the finger rest is on the mandible arch. So coming on to the extraoral fulcrum, we have two type of fulcrum. First one is palm up fulcrum and second one is palm down fulcrum. So in palm up fulcrum, these extraoral fulcrums are essential for effective instrumentation on some aspects of the maxillary posterior region. So in farmer fulcrum, we establish the resting, we establish the back of the middle and fourth finger on the skin overlying the lateral aspect of the mandible on the right side of the face. In palm down, the back side of the fourth finger and third finger will rest on the right side of the face. Whereas in palm down, we rest the front surface of the middle and fourth finger on the skin overlying the lateral aspect of the mandible on the left side of the face. Whereas fingers are resting on the left side of the face. This is again a video demonstration for extraoral fulcrum. So this is palm up fulcrum. We are resting the back side of the middle and fourth finger on the skin overlying the lateral aspect of the mandible on the right side of the face. See, in palm down, we will establish the finger rest by resting the front surface of the middle and fourth finger on the skin, overlying the lateral aspect of the mandible on the left side of the face. So coming on to the instrument activation. What is adaptation? Adaptation is manner in which the working end of the periodontal instrument is placed against the surface of the tooth. Precise adaptation must be maintained with all the instruments to avoid trauma to soft tissues and root surfaces and to ensure maximum effectiveness of instrumentation. Correct adaptation of probe is quite simple. Tip and side of the probe should be flushed against the tooth surfaces as vertical strokes are activated within the crevices. Bladed instruments such as curate and sharp pointed instrument such as explorers are more difficult to adapt because the tip of the instrument might injure the soft tissue or cause laceration of the gingival tissue. So we can divide the cutting edge of the instrument into three parts as the figure shows. This A part is the few millimeters just adjacent to the toe. This B part is the middle 1/3 of the cutting edge and C part is the upper 1/3 which is adjacent to the shank area. Angulation. The angle between the face of bladed instrument and tooth surface is known as tooth blade relationship. Correct angulation is essential for effective calculus removal. Exact blade angulation depend on the amount and nature of the calculus present and procedure being performed and as well as the condition of the soft tissue around the working area. So as the picture shows, 0 degree is the correct angulation of the instrument while you are inserting the instrument into the pocket. B shows 45 to 90 degree angulation, that is the correct angulation for scaling and root planing. C shows the angulation of less than 45 degree, that is incorrect angulation for scaling and root planing. And the D picture shows angulation of more than 90 degree, that is incorrect angulation for scaling and root planing, but this is the correct angulation while performing gingival curettage. So in this picture you can appreciate for correct angulation you will adapt the tip of the instrument at the midline of the working area. And if you are not touching the tip of the instrument close to the tooth surface, this pointed part of the instrument might result in laceration of the gingival margins. Coming on to lateral pressure. What is lateral pressure? It is the pressure that is created when forces is applied against the surface of the tooth with cutting edge of the bladed instrument. It may be firm, moderate or light. When removing calculus, lateral pressure is applied firmly or moderately initially and is progressively diminished until light lateral pressure is applied for final root planing strokes. Although firm lateral pressure is necessary for thorough removal of the calculus, indiscriminate and uncontrolled application of heavy forces during instrumentation should be avoided so that you have better control over the instrument. So we have three types of strokes. First is exploratory strokes, then is scaling strokes, and last one is root planing strokes. I will be discussing these strokes in further slides. So appreciating the picture, vertical stroke, see, when you are giving strokes in the vertical direction, oblique stroke when you are giving strokes in the oblique direction, and horizontal stroke when you are giving strokes in a horizontal direction. All of these basic strokes may be activated by pull or push motion in vertical, oblique or horizontal direction. Vertical and oblique strokes are used most frequently. Horizontal strokes are used selectively on line angles and deep pockets that cannot be negotiated with vertical or oblique strokes. So what is exploratory stroke? It is a very light feeling stroke that is used with probe and explorer to evaluate dimension of the pocket and to detect the calculus and irregularities on the tooth surfaces. Whenever you are doing scaling, root planing, with the help of tip of the explorer, you can always, using tactile sensation, you can always explore the area if at all there is any left or residual calculus is there. Scaling strokes, it is a short powerful pull stroke that is used with bladed instrument for removal of both supragingival and subgingival calculus. Third one is root planing stroke that is used for final smoothing and planing of root surfaces. Now we will be discussing principle of positioning. Neutral position for the clinician. In this picture, you can appreciate the position of the operator. In the first picture, you can appreciate the forearm. In this picture, you appreciate the position. This is the position of the operator. So the position of the operator should be as such. The forearms should be parallel to the floor. Weight should be evenly balanced. Thigh should be parallel to the floor, and hip should have an angle of 90 degrees. So the head can be tilted up to 0 to 15 degree of angulation, and you can avoid leaning too forward during instrumentation and try to maintain the neutral shoulder position while instrumentation. Patient position. Mostly the patients are positioned during dental treatment in a supine position that is almost horizontal or parallel to the floor. Patient position relative to the clinician. So first you adjust the height of your chair and maintain the angulation of 90 degree. Next, lower the patient chair until the tip of the patient nose is below your waist. Your elbow angulation should be 90 degree when the fingers are touching the teeth in the treatment area. And you should avoid placing the legs under the back of the patient chair. In this position, the patient will be too high and you will need to raise your arm to reach the patient's mouth. It is acceptable to place your legs under the headrest of the chair. So in this picture, you can appreciate neutral position of the operator. Patient's working area should be at your elbow level. Like you can appreciate in this picture. So this is very most common positioning error made by the clinician during periodontal instrumentation, that they position the patient too high in relation to themselves. So you have to keep the working area at your elbow level. Equipment position in relation to the clinician. So if you're working on the mandibular teeth, position the light directly above the patient head, and light should be as far as above as possible within your comfortable reach. And when you are doing instrumentation on the maxillary region, when you're doing instrumentation on the maxillary region, position the light above the patient chest, tilt light so that the light beams shine into the patient mouth at an angle. Position light as far as away from the patient mouth as possible while keeping it within your easy reach. So coming on to the different chair position. We have 12 o'clock position, 11 o'clock position, 10 o'clock position, 9 o'clock position, and 8 o'clock position for right-handed operators. So this is 8 o'clock position. We have two options for placement of your legs. First option is that you're crossing your legs, and second option is you're placing your legs under the head seat of the patient chair. So this is 10 o'clock position. First picture is showing 10 o'clock position, and this is 12 o'clock position in which you are sitting right behind the patient's mouth. Position for interior succinct. So when you are working on the interior region, you can position yourself at 9 or 10, 8 or 9 o'clock position and visualize this area, as well as mandibular interior region and maxillary front region. At 12 o'clock position, you can visualize the lingual aspect of the mandibular region and palatal aspect of the maxillary region. So coming on to the position for posterior succinct, you can sit at 9 o'clock position with patient's mouths slightly turned away from the clinician and chin down position. And in this position, you can do instrumentation on the buccal aspect of the mandibular region and lingual aspect of the other side of the arch, like this. And on maxillary region, you can assess the buccal surface as well as the palatal surface. At 10 o'clock position, you can turn the patient's mouth towards yourself and chin down position. And in this position, you can assess the buccal surface and palatal surface. And on maxillary, you can assess the palatal region of the same side of the arch and buccal surface of the other side of the arch, like this. These shaded area represent the area that can be assessed in this position. So we have position for left-handed clinicians also. It is 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock and 4 o'clock. Appreciate, you can use 4 o'clock position when you are working on the lower anterior region. Again, same, you have two options to place your legs, option 1 and option 2. 2 o'clock position, 12 o'clock position is the same for right-handed operator and left-handed operators. Position for interior sextant. For left-handed operator, at 4 o'clock or 3 o'clock position, you can turn the patient head slightly towards yourself and chin down position. You can assess the maxillary and mandibular lower anterior region. Like this, 12 o'clock. Again, these pictures are self-explanatory. Position for posterior sextant. For left-handed operator, at 3 o'clock, you can turn the patient mouth slightly away from yourself and chin down position. Like this. And at 2 or 1 o'clock, you can turn the patient mouth towards yourself and chin down position to assess the buccal and lingual surface of the mandibular arch and palatal and buccal surface of the maxillary arch. So thank you. These are the references of this presentation.